Good evening, ladies and gentlemen, and welcome to tonight's GPN Facebook Live. It's all a bit cold and lonely and wet in my office, so I apologise if I'm looking a bit sad. I know where Sarah is, it's equally cold and windy. So hopefully we'll get through this event without becoming too depressed or trees flying through windows. Tonight's event is called Effectively Managing Exudate by Making Every Contact Count. And our wonderful speaker tonight is Sarah Gardner. Good evening, Sarah.
Hi there, Ed. You doing all right?
I'm doing really well. Just feeling a bit sorry for myself on a Thursday night when it's soaking wet walking to the office. How are you?
I'm good. I'm good. Nice and dry.
Good. Well, thank you for your support tonight. Ladies and gentlemen, as you can see, Sarah is doing tonight's event from home. So if we have any technology issues or a tree does blow in through her window, bear with us, and I promise you we'll get it sorted as soon as possible. Tonight's event will be available on Facebook forever, free of charge. We'll also put it on our website where you can download all the slides. We always get about 57 questions during this event. Can we download slides? The answer is absolutely you can. The certificate of attendance link will appear towards the end of tonight's event. That will count towards your revalidation portfolio. As I'm sure Sarah will agree, the more involved you are, the more comments, the more questions, the better it is for us and the event. So please feel free to ask as many as you want, and we'll endeavour to answer as many of them as possible towards the end of tonight's event. Before we start, a massive thank you to our partners tonight, who are Hartman. Hartman have been a huge partner across our platforms the last few years of independent education, but in particular to the general practice nurse. It's a real passion for them, their leadership team throughout the business. So a huge thank you. Without this kind of support, these events simply could not and would not happen. So thank you from me and all the team. So without further ado, it gives me great pleasure to introduce you to tonight's speaker. Over to you, Sarah.
Thanks, Ed. Thanks for the introduction, and thanks for the opportunity to present to you tonight. Also, thanks for Hartman for supporting it. I'm an independent tissue viability consultant, but up until July of last year, when I moved up to sunny Cumbria, I did work for the NHS for 40 years, and the last 13 years I was leading a tissue viability team in Oxfordshire. I worked really closely with practice nurses throughout this time, so I do think, I hope I've got a good understanding of your role and the challenges that you face day to day, but particularly with wound care. I'm delighted to be able to share some ideas tonight that will hopefully make your clinical lives easier, as well as your patients' lives. So the title, Effectively Managing Exudate by Making Every Contact Count, does sound quite generic, but I will be focusing predominantly on the lower limb tonight. However, the general principles can be applied to all wound types. And as Ed said, if you have any questions at all, please post those into the Q&A box, and I can answer those at the end of this presentation. So the objectives of my presentation tonight really is to develop, for you to develop a greater understanding of the burden of wounds on the NHS in the UK, and to briefly explore the reasons for the unwarranted variation in lower limb care. Hopefully you'll get a better understanding of the role of exudate in wound healing and how chronic wound exudate contributes to delayed wound healing, and how to explore the unmanaged exudate impacts on your services, but also the patient's quality of life, and to identify how early intervention and making every contact count can improve clinical outcomes. So first of all, what is making every contact count? Now, as practice nurses, you'll probably be very familiar with this. So it is an approach sort of to behaviour change that uses the millions, if you think about all of those interactions every day across the UK from people like yourself, and that have with individuals, to support them in making positive changes to their physical and mental health well-being. It originally came out in, I think it was 2016, and it was sort of a document that was produced by Public Health England, NHS England and Health Education England, with lots of support from NICE, RCN, CQC, for example, to support population behaviour change and to help individuals and communities significantly reduce their risk of disease. But really, in terms of yourself, many of you have probably been using this, maybe taking an opportunity when somebody comes in, maybe to have, I don't know, just a blood test, that you make that opportunity then to talk to them about maybe smoking cessation or weight loss, for example, or improving their management of their long-term conditions. So you're taking advantage of that contact to deliver some education to your patients. It's not something that we've used in wound care, you'll probably admit, but actually when I was asked to do this presentation, I thought, why aren't we doing this? Because we have lots of opportunities to use this sort of model in wound care to hopefully prevent wounds developing in the first place, but to more proactively or to improve the outcomes that we're trying to achieve in wound care. So first of all, why do we need to adopt making every contact count in wound care? Well, from this graph, you can probably see that wounds are sitting halfway up that graph, and the spend currently, or based on 2017-18 figures, so they're likely to have gone up by now, was sitting at £8.3 billion a year. So that's above what we're trying to do to tackle obesity in the UK. So from the evidence or the study that this data came from, it was suggested that that figure will continue to go up. So if you look at these figures here, so the data supporting these figures here came from studies carried out by Julian Guest, who was looking at the burden of wound care in the UK. And the original study he did was 2012-13, and as you can see, the spend had gone from sort of £5.3 billion up to that £8.3 billion in 2017 and 18. And the number of wounds being treated by the NHS also went up in that 5-year period by over 1 million to 3.8 million, with the number of chronic wounds increasing from 43 to 49%. So clearly it's on the up, not the downward improvement. So something has to be done. And when you're looking at the wound types, if you look at this pie chart here, wounds that involve the lower limbs and the foot make up 37% of all wounds. But can you see that little block there, that slice of the cake that says unspecified? And it suggested that there's probably wounds to do with the lower limb included in that percentage. So we could be sort of 40 to 50% of all total wounds are associated with the lower limb. But interestingly, about 70% of those wounds will be associated with venous disease. And that is a condition that if you can identify the signs early and put a treatment plan in place, hopefully that will prevent people developing wounds. But if they already have skin breakdown, it will prevent it getting much worse. So, there's a real case here for early intervention. So at the moment, when you're looking at venous leg ulcers, for example, that original study that Julian Guest gave us the data for, we had healing rates at 12 months at about 47% for a venous leg ulcer. This last data that he's produced, that has reduced to 37%. So it's not going in the right direction. And this is why, we need to be looking at our practice and looking at the effective pathways that we can put in place that will improve that statistic. So these poor healing rates are a result of a number of factors, really. So poor assessment or no assessment at all will prevent a correct diagnosis being made. So if you haven't got a correct diagnosis, how do you know which pathway to put your patient on? Or if you do, it's possibly the wrong pathway. So there appears to be an underuse of evidence-based practice, which predominantly, if you're looking at lower limb, say venous leg ulcers, will be strong graduated compression and venous intervention for, say, venous ablation. There also appears to be overuse of ineffective interventions, which includes a rise in the use of reduced compression. And this ultimately will not be managing your underlying venous hypertension problem, which then will lead to slow or delayed wound healing. Unfortunately, there is also a lot of local policies that are outdated, or they're not evidence-based, and these will restrict the application of evidence-based treatment. And what that can result in is this ritualistic or historical sort of practice, which creates or inhibits the improvement of patient care. So it was the findings from Julian Guest's study that prompted NHS England to commission the National Wound Care Strategy Programme. And the lower limb stream forms part of a wider programme which includes surgical wounds and also the stop the pressure work as well. And they produce recommendations for the clinical care of lower limb and foot. And these evidence-based recommendations, if applied, they offer huge opportunities to improve healing rates, to reduce spend on inappropriate or ineffective treatments, and to reduce clinical time, and ultimately, most importantly, to reduce patient suffering. If you're not aware of this document, I really urge you to download a copy. Just go onto Google and put in the National Wound Care Strategy Programme lower limb recommendations. It'll come up and you can download it for free. It's a really easy read, easy to follow document, and sets out a really clear pathway for improving lower limb wound care. So how does making every contact count relate to lower limb exudate management? Well, firstly, it's about being proactive. What do you need to do to recognise any risks at an early stage? So, for example, what you want to do is prevent a wound occurring, or if someone has swollen limbs, for example, a lot of oedema on board, it does increase the risk of cellulitis, for example. So what do you need to do to stop that happening? If there's someone presents already with a wound, it could be a small wound, what do you need to do to prevent that wound from deteriorating? So if someone comes into your surgery, for example, and they've come in for another thing, nothing to do with their legs, but you do observe that they have got oedema, do you mention it? Have they got other signs of venous disease? If you have observed that they've got a bit of staining on the leg, varicose veins, do you do anything about that? What can you put in place to address this and prevent future complications? What educational resources have you got available within your surgery? Or can you signpost to something like Legs Matter, for example, their website? It's got amazing resources in there. So making every contact count is very much about preventing health problems occurring. And Legs Matter is very much about patient public education and prevention. So if the patient's already got a wound, do you know whether it's healing or not when they come to you? How do you know that? If it's a chronic wound, then it's likely to have some abnormal exudate already. So it's important that you know your exudate. And taking early action and managing exudate effectively will prevent those additional complications in the future and will aid healing. And again, the education of patients is really important for them to understand why their wound is like this, why you're choosing specific dressings, for example, and maybe why that you're recommending strong compression. So if they understand all of these things and they have some knowledge base around it, hopefully they'll tolerate their treatment plan better and make them a really positive partner in the care. So firstly, what is exudate? I mean, there are numerous definitions, isn't there, bandying about it. So it's that stuff that comes out of the wound, or it's wound fluid. And it's mainly perceived, you might agree, as being sort of negative, or a negative connotation about it, or it's seen as bad because of the challenges that you as nurses will face when involved in wound care. But exudate, you must remember, is an essential component for wound healing. and it provides an optimal condition for healing to take place. If you think about it, it will aid autolytic debridement. So if you have some sloughy tissue in the wound bed, it will help to debride, and it will help with cell proliferation, so those new forming cells to aid healing. So if you think about it also, you know, it will provide essential nutrients for giving cells energy, and also help diffuse that immune and growth factors essential for healing and the migration of those epithelial cells across the wound bed. If you didn't have adequate exudate and you had quite a dry wound bed, those epithelial cells can't migrate across the wound bed to help closure from the wound. But in chronic wounds, and I would imagine that most of you out there, a lot of the patients that you're seeing will have wounds that exceed that 2-week limit, so are now becoming more chronic in nature. So exudate does start to change and it becomes bad or harmful in nature, and it ultimately will lead to delayed wound healing or wound deterioration. What you'll find is they have higher levels of these pro-inflammatory cytokines, and that will result in levels of MMPs rising. And what happens then is that starts to degrade or break down the extracellular matrix. So all that lovely matrix that's formed in the early stages of healing will start to break down, and the wound will remain very inflammatory. So having these lower growth factors will slow down that proliferation and migration of cells, and therefore, you know, the fibroblasts won't form properly, which is an essential part of wound healing. So are there things that influence exudate production? Well, there are. Etiology is really important. So if a patient has venous disease or lymphatic disease, often what comes with that is the degree of oedema. And if you think about it, oedema present in a lower limb, and you've got a wound there, automatically that will be producing higher levels of exudate. The phase of wound healing is very important as well. So again, it's important to know the phases of wound healing. So in the early stages of wounding, higher levels of exudate is normal. You would expect that. That's good exudate. But if the wound is now chronic, but it's still chucking out huge amounts of exudate, that is not normal for the wound healing stage. That's not normal wound healing. And wound size, depth, and position are factors as well. So the bigger the wound, the deeper the wound, exudate is likely to be higher. And positionally, anatomically, if you had a wound, say, over a joint, or you had it in an area of friction, it is going to be producing more exudate. So also local factors such as infection, or you have to maybe think that, is there a foreign body in this wound? If there is a foreign body, that will be causing a sort of inflammatory response and will not recover from that until that foreign body has been removed. And then you need to be thinking about systemic factors. So they certainly do factor in exudate production. So certain comorbidities such as heart failure or renal failure may affect exudate levels. And people who are malnourished, they do increase the risk of having oedema because their serum albumin level tends to be higher. So you know, you might get that oedema present. You need to be considering that, serum albumin lower. So how does exudate then impact on your service as a clinical service? You know, it's far-reaching, from the nursing time, so the amount of appointments that a patient needs that impacts on your service that you're trying to provide beyond wound care. And you will get increasing levels of hospital admissions, often associated with infection. You know, we were talking earlier about the increase of sepsis in wound care. It is happening. And dressing costs can be significant due to the frequency of dressing changes. Patients are often put on multiple courses of antibiotics, often inappropriately, but in an attempt to try and manage that bioburden in their wounds. And there is an impact on healing as well. So, you know, you can tell from these images here on the screen that these are not healing wounds, are they? They're chronic wounds, and unmanaged exudate has contributed to this. You know, the peri-wound maceration will prevent that migration of epithelial cells that I talked to you about just earlier. And the wound edges and the skin excoriation, that will increase the risk of wound expansion as it breaks down. Lymphuria leaking from chronically edematous legs will also produce skin breakdown and ulceration. And these cases are often referred to as wet legs. You know, wet legs is not a diagnosis. The diagnosis is the underlying cause that is causing the skin to break down or the skin to be as wet as it is. So you need to get to the root cause of this. The problem needs treating if the wet legs are to improve. But, you know, massively, really significantly, there is an impact on the patient's quality of life. So put yourself in the life of a patient who has a highly exuding wound or experiencing lymphuria, for example, from their edematous legs. Imagine the leakage seeping through the dressings and the bandages onto your clothes, excuse me, onto your furniture, onto your bedclothes. You know, the amount of changing of clothing and your bed linen. Imagine sharing a bed with your partner when experiencing wound leakage. What does this do to your relationship? Imagine the smell, the embarrassment of having people come to your house. You know, you stop going out because of the leakage. You've been given multiple courses of antibiotics because of the infection or potential infection. And that, in addition to the smell, has really put you off your food, so you've lost weight, and therefore you're feeling weaker as a result. The pain is terrible. It burns constantly. And when the nurse comes to change the dressings, you feel like screaming. It's so painful. It's all getting you down. You can't get about as well as you used to be able to because of the wet dressings, and you feel low in mood and you're tearful. There doesn't seem to be an end to it. You know, I recall a gentleman I saw some years back who, when I went in to see him in his house, he was sat with his legs in bowls, washing up bowls with the fluid just dripping into these bowls. You know, imagine living with that. It's an unacceptable situation. So we need solutions, folks, don't we? We need to make every contact count. You know, we need solutions for preventing scenarios like this happening. Or if faced with that scenario today, what do you need to do today to improve that situation for your patient? So by making every contact count, you're acknowledging there's a problem, but you need to do something about it today. If the patient comes in for a blood test or a checkup for a long-term condition and you notice they've got swollen legs or they've got some venous disease signs like hemosiderin staining, atrophy blanche, acknowledge this and take action today. It may not be possible for you to do anything practically today, but you could advise the patient to book another appointment to come back to talk to you about it, or you could issue them with some advice sheets, for example, or you could signpost them to the Legs Matters website. You know, if the patient presents with a new wound, make every contact count and take the correct action today. So the National Wound Care Strategy talks about immediate and necessary care. You know, a minimum standard that should be applied to all patients presenting with a wound, and the importance of referring that patient to a clinician who has got additional legal skills for assessment if you deem that patient's got a slight, you know, a complex wound. And referral should be made within 24 hours of the patient presenting, and they should be seen within 14 days. Can the patient self-care with support? What do you need to do today to enable that? So making every contact count benefits clinical services as well as the patients by supporting a self-care model. So fewer patients need to be seen in the clinic, and therefore it frees up you to do the more complex clinical care that you're really brilliant at. Education is absolutely essential to support self-care. So again, make sure you've got access to good resources that patients can utilise in order to improve their knowledge and understanding of their condition. So when managing a patient with a highly exuding wound, you need a clear plan in place that's holistic in nature and would be designed to optimise the patient's condition, so any underlying conditions contributing to the exudate, as well as their quality of life, but also managing the wound and the exudate itself. So it's important to identify the underlying causes of that abnormal exudate level and to look at a strategy for managing it that would include compression therapy, appropriate dressings, and skincare. So making every contact count means that you have acknowledged the underlying problem and have the knowledge and skills to address this problem. So for example, you've recognized the signs of venous disease and understood that the gold standard treatment is strong compression and a referral to the vascular team for assessment and intervention. So for making every contact to be effective, this needs to be immediate. So putting off this action will probably result in the wound to continue to deteriorate and potentially the development of more serious complications. Has the patient got heart failure? What sort of heart failure have they got? Is this a new diagnosis? Is it stable? In most cases, compression therapy is safe to apply for these patients, but in doubt, if you've got any doubt at all, your making every contact count decision will be to seek advice from a specialist. Not doing this will not only result in the wound deteriorating, but it's that delay, isn't it? It will delay wound healing. So low serum albumin can result in lower lymphedema, which in turn would increase exudate levels. So why is it low? Is it because it's secondary to nutrition? So what do you need to do today to address this? So in terms of nutritional advice, for example. So it's not always possible to improve the status of some conditions. Renal failure in the later stages is really difficult to manage. It's more palliative in nature. But again, making every contact count means you're considering this as a factor in exudate management and doing all you can to improve the situation. So in terms of compression therapy, it is the gold standard for managing wounds or conditions associated with venous disease. And making every contact count means that compression should be commenced the day the patient presents with a lower limb wound, following assessment against these 5 red flags that you can see on the screen here. So if all of the red flags are absent, then mild compression can be applied today in order to start the healing process, and that's without an ABPI. And I know it's like, oh my God, shock horror, but if they haven't got these red flags, we're giving you permission to do that. So this could be hosiery, class 1 hosiery, it could be a reduced compression bandage. So self-care should be considered at this point. So if the patient's had a wound for more than 2 weeks with no signs of healing, please do refer to a clinician with additional leg ulcer management skills for assessment. And they should be seen within 14 days, as I say. Now, that doesn't need to be a TVN. It doesn't need to be a leg ulcer clinic. It could be you. You've done a leg ulcer course, but you can't see them to do that today, but you're going to bring them back within 14 days to do that. So at this point, making every contact count means that following a vascular assessment, strong compression is applied, and that is then speeding up that healing process. So making every contact count is around optimizing wound health and peri-wound skin as well. So cleansing is essential to remove wound debris and to assist the debridement of devitalized tissue. Other methods of debridement may be required. So what is the action required today, to enable this? If the wound's infected, what are your treatment options that you need to be delivering today? What is the status of the peri-wound skin today? How can you improve this? Do you need to consider a skin barrier until the skin starts to recover? Or is there emollient therapy in place? If not, can you start this today? This will certainly start re-nourishing and rehydrating the skin, restoring that damaged barrier function. So making every contact count also means selecting the appropriate dressing today. What dressings have you got in place? Are they effective? This is a list of the properties of an ideal dressing. There's quite a lot of them there if you look at them. Do you always consider all of these criteria when choosing your dressing, or do you just have to select from what's available to you from your cupboard, for example? In exudate management, it's really important that essentially we need to choose a dressing that's going to prevent strike through and leakage, hopefully extend the wear time, So that's minimizing disruption to the patient, but also to you as a service, and also have suitable fluid handling capacity for the level of exudate that you've assessed, and to be able to retain that under compression. In addition, it should be comfortable for the patient and be atraumatic on removal. So it is therefore important to know how dressings work in order for you to select appropriately for your patient's needs. So having this knowledge will make every contact count when it comes to deciding on a dressing. So when considering exudate management, let's look quickly at how dressings work. So some dressings will work by absorption. So they absorb fluid and hold it within the dressing material. So basic cotton pads, some foams will come into this category. Other dressings are able to absorb fluid, they form a gel and may have a combination of absorption and gelling as well. So examples include alginates, the carboxymethyl cellulose fibres, and the superabsorbent polymers. Another mode of action is through evaporation, and these dressings allow moisture to evaporate from their outer surface, and is known as the moisture vapor transmission rate. So what dressings are frequently used in the management of exudate? So foams are a popular choice, but there's variation in their fluid handling capacities, and I would suggest caution when considering a foam for managing higher levels of exudate, and certainly when applying under compression. These products will only hold a certain amount of fluid before it spills out onto the peri-wound skin, and so you need to bear that in mind when selecting a foam product. Alginates are also commonly used, and they help to debride a fluffy wound as well. So it is a combination, as well as managing exudate, they will debride. A secondary dressing is required with an alginate, so you need to consider how the two work together, but also independently. Superabsorbent polymers are now a popular choice for due to their fluid handling ability, but it's important when making this contact count that you understand the mode of action in order to make it a cost-effective choice. So what are superabsorbent polymers, or SAPs as they're commonly known by, and what do they do? So as the name suggests, they're superabsorbent, which makes them a step up from a simple absorbent pad. They're ideal for highly exuding wounds, and they work by changing their structure when in contact with wound fluid. So it results in swelling of the polymer strands that are within the dressing. They help to modulate MMPs, which is really good because they bind them. And if you can reduce that level of MMPs, it will hopefully reduce that inflammatory process in the wound. But they also have a high level of moisture vapor transmission rate as well. So the fluid handling ability helps to prevent wound leakage and strike through, but there will still be a limit for its ability to hold fluid. You know, this is not a panacea for massive exuding that will hold it for a week. You know, there's still going to be a limit, but they're really effective with the amount that they can hold. So as fluid is being retained within the dressing effectively, there's a less chance of that peri-wound damage, and therefore this will enhance that epithelialization of the wound edges. It's a great dressing to use under compression as it stays intact and it's very comfortable for the patient. Now, depending on the SAP used, there will be some swelling of that dressing. And some people do worry that it may be increasing that sub-bandage pressure and might cause some pressure damage, some harm to the patient. This has not been proven to be the case. And certainly there is more harm being done by not applying compression or not using a suitable absorbent pad. So what you shouldn't be doing is applying the dressing on top of the bandages, which I've heard does happen occasionally. This will inhibit the true performance of the dressing, and imagine having to live with that treatment approach. So when making every contact count, what do you need to do today to make your decision effective? So base your decision on holistic wound assessment. Have a good understanding of the dressings that you're using. You know, what is the mode of action? Do you understand that? And if you don't, speak to the companies that provide it. They know their dressings more than anybody else. So ask for that information. What are you trying to achieve here? Is your patient in agreement with you? Because if they're not, you're on a road to nowhere. And when choosing a dressing, what size is required? Choose a dressing or a size that's in line with the wound dimensions. You don't need a 40 by 20 pad that you're going to wrap around the leg if the wound is only, say, 10 centimeters in diameter. You know, adding bulk can increase discomfort, reduce mobility, and can interfere with the effectiveness of the compression. Think of where anatomically the wound is. Do you need to have a dressing that will conform with the site, at the same time capturing the exudate effectively? You know, a good example of that is these retromalleolar ulcers. You know, so you need to have a dressing that you can place that will conform to the anatomical site. Don't be tempted to layer dressings, folks. This is absolutely counterproductive and will only result in unnecessary costs, and you know, you're not going to be managing the problem. Is your patient self-caring? If so, this, you know, will the dressing that you choose be a good dressing for them to be using independently, and particularly under compression hosiery? You know, you might wish to choose a super absorbent polymer dressing, such as maybe Zechivit plus silicone border. That is ideal dressing for under hosiery. Patients can use that effectively. It's great for pulling hosiery over, but it will manage the exudate well, particularly if they've got a painful wound or some fragile peri-wound skin, because the silicone nature will protect that. And ultimately, will this dressing be cost effective? You know, will it do what it says on the tin and have a positive impact on your service as well? So in summary, how do you make every contact count when managing a patient with exuding wound? I'd like you to be proactive, be observant, and take early action when you've identified a problem. You know, stop problems occurring in the first place by providing advice and education to your patients on preventing lower limb conditions, and signpost them to the resources such as Legs Matter website for more information. Where possible, support self-care, but if patients do present with a more complex wound, identify any potential problems through a robust assessment, which will help you identify the cause of high exudate levels, and then treat that cause, whether it's due to infection or inflammation, or because of venous insufficiency and strong compression is needed. And finally, don't forget that dressings are an important factor, an important partner in this management plan. So ensure you have a good understanding of the dressings you have available, and choose the one that you know will manage the level of exudate effectively, and that will assist you in you and your patient on their journey to healing. So many thanks for listening, and now I'll be happy to take your questions.
Sarah, that was brilliant. Ladies and gentlemen, thank you for all your comments, all your questions, and your kind words. Sarah, if you get a chance, look back at this, because there's some amazing comments and some very kind things being said. So thank you very much. Before we start with the questions, Hartman have got some really cool education. The web address we put up now, it is hartmanmarketing.com/event/, not just on exudate management, but leg ulcers, pressure ulcers, and a variety of other things. So go there now, and the link should appear in the comment bar for your perusal. Sarah, are you okay if we kick off with the question?
Yeah, sure. Off you go.
So we've got a few. So number one, what is the best way to dress a wound in an awkward area, such as a pressure ulcer to the sacrum?
Yeah, so you need to make sure that the dressing that you're choosing is going to perform under friction, particularly unless you've got your patient off that anatomical area, which is a problem. A lot of people don't like lying on their side, so they prefer to lie on their back, even though obviously if they've got a sacral sore, you're trying to offload them. So it's a dressing really that's going to conform and is going to probably, I would say in a sacrum, provide a seal that's going to hold it in place, but also will contain the exudate and not move as the patient does. So one that performs well under friction and will absorb. Sacral pressure sores do, or pressure ulcers, sorry, sores, where that came from, do tend to be wetter. So especially when they're starting to debride, you do need something that's going to perform well in terms of absorption. But something that, yeah, it's around the friction, I think, for that.
Brilliant, thank you. Precious Sores came from 1998, which was about 2 years after I started working in tissue viability. And so I saw my first, well, it was called a bed sore actually in 96.
Oh, bed sores, oh, absolutely, yeah.
Bed sore in 96, precious sore in 98, and then it's gone from there. So I know exactly where it's come from. It means I'm showing my age, which is
Oh, don't.
Question 2. How can we support patients who are unable to go to bed and have heavily exuding wounds to their legs?
Oh gosh. So unable to go to bed, you say?
Yes.
So obviously there's the unable and the unwilling.
Yeah.
So I would say if they're unable, you need to explore why they're unable. And I know there's a whole list of reasons for unable. You know, if it's something, I had patients that had panic attacks if they went to bed because they thought they were going to drown in secretions or not be able to breathe just when they go to bed. So getting around that psychological reason is really tough. If it's physically unable, they can't lift heavy legs into bed, have you referred? Have you, wound care is not just about nursing, is it? You know, we have to be multidisciplinary. And I think people like OTs and physios are so more involved now in supporting nurses with some of these complex cases. So OTs have all sorts of amazing aids now to allow people to get their, or enable their people to get their legs into bed. So if you haven't done that, I would urge you to do that. I don't want to support people sleeping in riser recliners. I think it's, we then create problems with pressure damage to sacrums. But I would say speak to your OT and your physio about how they can enable. Have they got a hospital bed, for example? Have they got the right equipment? But ultimately, if they've got heavy legs, we need to be managing that so we can reduce the oedema and improve that sort of functional ability of the limb. They might be able to get into bed easier anyway.
Brilliant, thank you. So question 3 is probably the most common question we've been asked over about the last 20 years and continues to be so. Can you advise on how to decide which dressing to use for a wound?
Oh my goodness. Well, there was that list that I had up on one of my slides. So again, it goes down to what are you trying to achieve? It goes down to your wound assessment. So it's whether it's just protection and it's a superficial wound, whether you need to debride, whether you're treating infection, or whether it's varying levels of exudate. But to me, this needs to be something that is going to be comfortable for the patient, to manage the conditions of the wound, will stay in place. So its wear time is greater, because really patients don't want their wounds dressed every day, and you don't want to be bringing them into your clinic every day. It's inconvenient for the patient and yourself. So you want decent wear time, something that will stay in place, is comfortable for the patient, and is not painful on removal, but also a dressing that maybe the patient can self-care with, because I really feel passionately that we need to be doing more supported self-care. But the bottom line is it's dependent on the conditions of that wound and what you're trying to achieve.
Yeah, thank you. I think you're right. I think the role of the patient is becoming increasingly challenged. 20 years ago when I started, it amazed me how little the patients seem to be involved in wound care, and that seems to be changing dramatically pre-COVID and post-COVID.
Yeah, I think it's certainly increased patient or supported self-care during COVID. We haven't always got it right, because it should be supported self-care, but I think it's the way forward, definitely.
100% agree. So question number 4. Patients like the look and feel of foam dressings, but I often think the wound looks macerated when removing the dressing. What do you advise?
Again, it's down to patient education. So if you can explain the mode of action, and why maybe you need to step up to something like a super absorbent polymer, for example, the reasons why. It's just education. It is. I absolutely agree. It's that lovely spongy soft feel, but if it doesn't perform, it's not doing what it, what you want it to do, and explaining the detriment and how it maybe is delaying wound healing. And I'm sure the patient wants their wound to heal. So if they have some knowledge base around, images, photographs are great, aren't they? Taking photographs and showing them maybe the maceration that this ineffective dressing is having is quite powerful. And it could be that you choose to step back down to a foam once you've got to that next stage of healing. It doesn't mean that you're not going to use them at all. It's just that at that point, it's not ideal. So education, imagery to show the patients maybe will help.
Brilliant, thank you. Question 5 from Jenny. Thank you, Jenny. So much reduced compression in use. How do you suggest we overcome staff fear around full compression?
Yeah, well, if anyone's got an easy answer to that, please just, email me. I've been trying to do this for years and years. I'm interested to know where it all started, Ed. When I first started as district nurse many decades ago, there was no fear around compression. I don't think we had access really to reduced compression or proper reduced compression. I think we need to be making nurses more confident with their decision making. I have people who do a wonderful ABPI, it's absolutely accurate, but then doubt themselves and therefore on the safe side will put reduced compression on. So we need to tackle that. We need to give nurses confidence. So there maybe needs to be more support in practice to supervise and to, encourage and support. But, going back to those red flags, use that as your guide. And if patients haven't got those red flags, yes, it's safe to put reduced compression on. But then, if you've done that proper assessment within 14 days and you've ruled out any serious arterial disease, get it on. It's safe. But you need to have faith in yourself. If you've done the training, you know what you're doing, you've done a good assessment, have faith in yourself. But maybe, it's more supporting clinical practice. That theory practice gap is massive, and we need to try and narrow it and give people a bit more support, maybe.
Yeah, I think you're on the money. I also think I've seen nurses communicate brilliantly with the patient, firmly but positively, as to the impact good compression will have, patient tolerating that good compression. And when communicated appropriately, in my experience, you see so many better outcomes with patients based on that empowered communication rather than, as you said, that nervousness and fear.
Well, I think, unfortunately, there's a lot of patients will have pain with their legs because of edema. And of course, if you're starting to talk about putting strong compression on, they think you're absolutely balmy, don't they? You want to put this strong compression bandage when I've got so much pain. And I think, again, it's having the confidence to relay that information, to explain to the patient that the reason why they've got pain is because of their venous disease, because of the edema. And that if you can get strong compression on, the likelihood is even as soon as 24 hours, their pain level will have come down, that congestion will be less. But they have to have trust in you and faith in you. So you need to be confidently relaying that information, which I know that people have the ability to do that, but have faith, as they say. You're good at what you're doing and just do it.
Brilliant, thank you. Question 6 from Claire. Thank you, Claire. What method of documentation do you advise to estimate the volume of exudate during a wound assessment?
Yeah, there's all sorts of, unless you're in a sort of research area where they're weighing pads full of exudate, we're not going to do that. So, we used to just go with the low, medium and high, and it used to be based on low exudate is the dressing change with no strike through is you can do it once a week. Medium or moderate levels of exudate, it's that you're containing that exudate within the dressings that you're using, and you're visiting 3 times a week. And then high is you're having to go in every day, or you've got strike through. So, you know, there's a lot. Maybe Hartman will, I'm sure, have some sort of tools that they use for measuring exudate, but we used to use that sort of model. So it's based on dressing frequency. Yeah, that's what most people do, a low, medium and high.
Thank you. Next question from Gail. How would you manage patient compliance and concordance?
So it's an interesting terminology. And interestingly, because I'm part of the Legs Matter coalition, and we have patient partners on our group. And at one meeting, we were talking about patient concordance and non-concordance. I can't remember what the conversation was, but we mentioned that terminology. And one of our patient partners was looking at us very confused, and she didn't even know what that was. So I think what we're doing is we're using that terminology, but we're not actually sharing that with our patients. We're not saying to them, we think you're non-concordant or non-compliant, and what that actually means. And I'm afraid I'm a bit of a devil's advocate, and I would say that I think the problem is often with the clinicians, not with the patient. Yeah. Because maybe we are sitting quite rigidly to, this is what you're being offered, and if you don't like it, tough luck sort of thing. But I think it's around, we need to explore, when we're labeling patients as non-concordant or non-compliant, why is that? So is it because of pain? Is it because they don't like the bandages that we're putting on their legs? Is it we're not listening properly? So I use a lot of motivational interviewing to get to the crux of why people aren't happy with their treatment plan. But I really would urge you to think about the terminology that we use, because often people aren't deliberately not adhering to treatment plans. It's because it's interfering with their lives in some way, and we need to look at another solution. Yeah. For example.
Thank you, Sarah. So question 8 from Carly. Do you recommend using the lymphedema wet leg pathway?
Yeah. So I do. I think the British Lymphology Society have produced amazing documents, and yes, any resources like that. And I think also the British Lymphology Society have been brilliant, because again, they are giving us permission to put compression on as well, because wet legs ultimately is usually down to venous disease that has then an impact, a knock-on effect on the lymphatic system. And therefore, the sooner we recognize that and get a decent treatment plan in place in terms of compression, the better. But we know people with big limbs are sometimes difficult to Doppler. And therefore, if people don't Doppler, they then don't engage in a treatment plan that includes high or strong compression. There's a fear in case they've got arterial disease. And the British Lymphology Society are giving us permission, you know, to, again, check holistically. But if you can't, get compression on, because the likelihood is you're doing more harm than good if you don't do that. So yeah, absolutely. They got some great resources, and I would say use them.
Brilliant. So question 9 from Susan. Thank you very much, Susan. Are you able to advise if Scotland has a comparable document to the National Wound Care Strategy Partnership?
At the moment, I know that we have had conversations with the equivalent of the Tissue Viability Society in Scotland, and that, you know, they are doing something similar. It is transferable, but obviously this is around NHS England. As far as I know, they haven't adopted that, but certainly it seems to be that the pathways in place are very similar or want to be adopted. So I absolutely agree that this should be a 4 nations approach. It's ridiculous that we do anything that's different than that. But it was the NHS England that commissioned the National Wound Care Strategy Programme. But there's certainly interest there.
From thank you. And our last question. So we are nearly there, Sarah. So thank you so much for being so amazing tonight. So the last question, question 10, from another Jenny. As a student in primary care, I saw several ulcers who were not recovering no matter what was tried. Are there some ulcers that can't be healed even when they don't have diabetes?
Really good question. And in fact, I was having a conversation only today with someone else about this. So I absolutely agree that there will be some lower limb wounds that will never heal. And we used to call them we used to put people on palliative wound plans. But we had a criteria that was applied to that patient scenario as a bit of a checklist, that everything that at all possible needed to have been tried had been tried. It's not for us as an individual to say that this wound will never heal. It's more of a multidisciplinary approach. So I would say that certainly a vascular surgeon needs to be involved, the GP needs to be involved, tissue viability needs to be involved, and yourself as a clinician. All of you need to be having that conversation. Has everything that possibly could be tried been tried? We know that because there's some really poorly people out there, and because of their long-term conditions, healing will be difficult. And I have never said we will never heal this wound. I would use the terminology unlikely to heal because of, but we used a checklist and then we put people on a palliative wound plan. But we didn't give up on them. We still managed that wound with all the right conditions. And in some occasions, there was improvement. We might not have healed them, but we made their quality of life better. So I would say, consider more widely before we say that. But yes, there are some wounds that won't ever heal, I would imagine.
Sarah, thank you so much for the questions and also the presentation. The response has been fantastic. So thank you, everyone out there.
Very
for
welcome.
Engaging in the way you have. I mean, hundreds and hundreds of comments. So thank you. Guys, there's some fantastic education on the Hartman website. Please go and have a look. Genuinely, some incredible stuff there. Also go onto our website for events like these, for our journal, for e-modules. Would love to welcome you there. As far as tonight's concerned, Sarah, thank you.
You're welcome. Really enjoyed it.
Put in tonight, but also before. Big thank you to Mole Digital, to the GPN team. You guys know who you are for all your work tonight. Again, thank you to Hartman for your support. Visit their website, and thank you for your commitment to independent education. And last but not least, to you guys out there who've given up an hour of your time to learn, to be the best you can. You continue to inspire me and the team. So thank you for everything you do. Have a lovely evening. Stay safe, stay strong, and we look forward to seeing you at one of these events in the near future. So thank you so much.